You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for August 8th, 2025. This week, listener feedback on the SURPASS cardiovascular outcomes trial, AF ablation, and the limits of meta-analyses, a Watchman alert from FDA, and oral anticoagulation choices in elderly patients. First up is that diabetes specialist Andreas Anderson from the Herlev Hospital in Copenhagen, which I have visited and given a lecture at, writes in about my coverage of the SURPASS cardiovascular outcomes trial comparing tirzepatide versus dulaglutide last week. The study results came as a press release. Eli Lilly, the makers of tirzepatide, announced that their drug proved non-inferior to dulaglutide for cardiovascular outcomes in patients with diabetes and established heart disease. The results of the SURPASS CVOT trial was that the risk of cardiovascular death, heart attack, stroke was 8% lower for tirzepatide versus dulaglutide. That hazard ratio was 0.92, and the confidence intervals went from 0.83 to 1.01, but this was a non-inferiority trial, and it met the non-inferiority limits. Tirzepatide also showed consistent results across all three components of the MACE-3 composite endpoint. The rate of all-cause mortality, interestingly, was 16% lower for tirzepatide versus dulaglutide, and that hazard ratio was 0.84 and statistically significant with confidence intervals below 1.0. There were also positive results in secondary endpoints such as a slower slope of eGFR decline, more reduction of hemoglobin A1C, and more reduction in body weight, minus 12% versus minus 5%. I was critical of the trial. A, there were no differences in hard CV events such as CV death. B, the all-cause mortality signal was likely noise as it was not driven by major reductions in CV outcomes. C, tirzepatide was dose increased, but dulaglutide was left at one dose. And D, I hated the idea of non-inferiority because tirzepatide really offers no cost or convenience over dulaglutide. Now, Andreas writes, while I agree with most of your comments, I believe the trial may not have been placed in the proper context. He said that I criticized the use of an active comparator in a non-inferiority design, and while this is not optimal, there are specific reasons for this trial design. And he listed 5 of them. First, such a trial is required by FDA and EMA. Remember, we have to conduct cardiovascular outcomes trials for all new diabetes drugs. This is to establish cardiovascular safety, not necessarily cardiovascular benefit. And I would ask readers to remember the rosiglitazone trials gave us the SGLT2 inhibitors. Of course, today, most companies would aim to establish benefit for a GLP-1 receptor agonist and would therefore prefer placebo as a comparator, but due to well-established effects of GLP-1 agonist on cardiovascular outcomes in patients with diabetes and heart disease, it is considered now unethical to conduct the cardiovascular outcome trials with placebo. Hence, Dr. Anderson writes, you are unlikely to see such a trial ever again in type 2 diabetes for a GLP-1 receptor agonist. His third point, that when using an active comparator with an established effect, you need a huge sample size to establish superiority. Fourth point, tirzepatide has demonstrated superior effect on hemoglobin A1C and weight compared to guideline-recommended GLP-1s that have established cardioprotective effects, such as dulaglutide and semaglutide. Therefore, he suggests it would be the preferred option for many patients with type 2 diabetes, but in patients with type 2 diabetes and atherosclerotic vascular disease, guidelines would still recommend semaglutide or dulaglutide. And his fifth point was that in this context, the full results from the SURPASS CVOT are very likely to be sufficient to incorporate tirzepatide in guidelines for the treatment of type 2 diabetes with atherosclerotic cardiovascular disease or high CV risk, and it offers a superior treatment option for glycemic control with a non-inferior effect on cardiovascular outcomes. And I really like this comments. These are good. Thank you. I learned something. And of course, I love Herlev Hospital in Copenhagen. All right, next topic is catheter and surgical AF ablation. A listener sent me a huge meta-analysis published in the Annals of Internal Medicine recently, and it compared catheter and surgical ablation to no ablation in randomized controlled trials. I had seen this study but ignored it. But when an avid listener say they are keen to know my thoughts, I re-looked at it and let's discuss it now. A group at Washington University in St. Louis led the study. It was a massive meta-analysis encompassing 63 trials with more than 11,000 patients. There were 39 catheter ablation trials and 24 surgical ablation trials. The goal was to bring together all RCTs in the field to assess the primary outcome of ischemic stroke at more than 30 days. Pause there. Stop and think. This is weird. Why ischemic stroke after 30 days as a primary outcome? What if a stroke happens at day 29? How is that less important than a stroke at 31 days? The authors of the meta-analysis also looked at secondary outcomes of mortality and heart failure hospitalizations, and I should say that 6 news outlets have picked up this study, all with positive headlines, but we need to look deeper at this. So the main results were that compared with medical therapy, catheter ablation reduced the risk for ischemic stroke after 30 days. It has a ratio of 0.63. It reduced the risk of mortality, 27% reduction, and heart failure hospitalizations by 32%. However, catheter ablation increased the relative risk for ischemic stroke at or before 30 days, and here the hazard was 6.8, with very wide confidence intervals from 1.5 to 29x. The surgical ablation reduced the relative risk for ischemic stroke and stroke from any cause, but had uncertain benefits for other outcomes. Ischemic stroke after 30 days in surgical ablation trials, the relative risk were 0.63, and this was non-significant. It was also non-significant for mortality and heart failure hospitalizations. Now, this is lacking, isn't it? You want to know total stroke, total mortality, and total heart failure hospitalizations. You also want to know about the absolute risk reductions. So here they are. For catheter ablation, total stroke had a non-significant 33% relative risk reduction, 0.77. The confidence intervals go from 0.57 to 1.05, so that's not statistically significant. The absolute risk reductions went from 6 fewer per 1,000 to 1 fewer per 1,000 cases. For total mortality, catheter ablation had a significant 37% relative risk reduction, and here the absolute risk reduction was 16 per 1,000 fewer. Heart failure hospitalizations had a 32% relative risk reduction, and the absolute risk reduction was 24 fewer per 1,000 hospitalizations. For surgical AF ablation versus cardiac surgery alone, total stroke, the relative risk reduction was 0.54, and the absolute difference was 25 fewer per 1,000. And as I mentioned above, there were not significant reductions with surgical AF ablation in heart failure hospitalizations or mortality. And so the authors of this sweeping meta-analysis concluded, quote, catheter ablation reduced the risk for ischemic stroke at more than 30 days, mortality and heart failure hospitalization. Surgical ablation had uncertain benefit except for stroke reduction. Now, a neutral reader would conclude that total stroke, mortality, and heart failure all trended lower for catheter ablation. I'm quite surprised that the accompanying editorial from Beth Israel key opinion leaders was quite positive. My comments, I am not at all positive about this meta-analysis, and I am surprised by how many key opinion leaders in AF there were as sub-authors of this paper. I think the main, perhaps only value of this meta-analysis is how it displays the weaknesses of meta-analysis and what should not be done. Now, before I mention the specifics of this meta-analysis, it's a good time to do some basics of meta-analyses which combine studies to hopefully, ideally, come to a summed effect size. I am not a statistician or trialist, but meta-analyses, in my mind, can really shine when individual trials are underpowered because of low event rates. If 2 or 3 or 4 trials are similar, you can combine and increase the power. I think of the NOAA and Artesia studies, the trials of DOACs and subclinical AFib. Each of these trials had low stroke rates, each were similar, and combining them increased power. Another example is the risk of AFib with fish oil. Each trial of fish oil showed an elevated risk of AF. Why? I don't know, but together the signal of AFib was stronger. Another area where meta-analyses may be helpful is finding a dose-response relationship, like in the fish oil and AF examples. Trials with the highest fish oil concentrations had the highest risk of AFib. Another area of meta-analysis might be when individual trials show conflicting results. Here, if the trials are similar, you might sort out the direction and magnitude of effect. But, inherent in deriving any benefit from meta-analyzing trials, you need to combine trials to enroll similar populations, have similar interventions, ideally have similar outcomes. You want the included studies to be high in quality and of the same clinical scenario. For instance, it's madness to combine ICD trials from the 2000s to now, as heart failure therapy has changed so much. This meta-analysis fails in nearly all of these facets I just mentioned. It's so weird that this many smart academics thought it to be a good idea. First problem, the endpoint is mind-boggling. You don't look at stroke before and after 30 days. You look at stroke overall. One group gets a procedure that could increase short-term risk of stroke, say for instance from the manipulation in the left atrium, but it might reduce stroke in the long term by decreasing AFib. So you only care about stroke overall. The example in the left atrial appendage trials where the only positive result was excluding the week after the procedure in Prevail, the secondary co-primary endpoint. And this was ridiculous because no patient can exclude the time after a procedure, whether it's a week or 30 days. Second problem, the authors combined trials from 20 years ago to trials done now. This is almost equally ridiculous because modern ablation is very different from the hocus pocus that we did in 2004. Third problem, the vast majority of included studies had a handful of patients. Combining small studies is a recipe for overestimating effect size. If you combine 10, 20, 30, or 40 single center studies, that cannot come close to estimating effect size compared with, say, a 2,000 patient strong Cabana trial. It's foolish to combine tiny studies with massive studies. Fourth, the authors looked at outcomes that were not primary outcomes of the major trials, and without individual patient-level data from each trial, who knows if the results are accurate. Fifth, the trials varied too much in trial conduct, endpoints, time of study to combine them together. The heterogeneity is off the charts. In sum, this massive effort yields exactly zero new information. And I mean no malice to the authors, but this was destined to fail. Meta-analyses have a role, but this is not it. Catheter ablation of atrial fibrillation should be studied. We should have trials with proper primary endpoints, such as stroke, death, and total hospitalizations, not heart failure hospitalizations. And if we want to study quality of life, there's only one way. You must have a placebo or sham control arm. Otherwise, you fail as hard as the tricuspid valve interventionalists have failed. All right, third topic today is Watchman air embolism alerts. On Wednesday, FDA sent an alert on Watchman access systems that was linked to at least 17 procedural deaths, and the problem was air embolism in the left atrium. FDA announced that there have been 120 serious injuries along with these 17 deaths. And here is another pause to stop and think. 17 deaths and 120 serious injuries. No, this is not a lot statistically. It's not. But you have to remember that patients sent for Watchman are fine the day they have the procedure. They are gambling that the upfront procedural risk is less than the risk of stroke or bleeding and death from AFib-related stroke in the next 5 to 10 years. So, if these 137 patients listed in this FDA alert had not died or sustained an injury from the procedure that day, They would have had a nice lunch and dinner and walk with the dog that evening. Never forget, my friends, that left atrial appendage is a preventive procedure for something yet to happen and may not happen. So here are the specifics. Boston Scientific sent a letter recommending changes in instruction for use. Basically, the company says that air embolism happens mostly in patients under conscious or deep sedation, especially in the presence of hypovolemia or partial airway obstruction. Negative left atrial pressure may increase the risk of air ingress through the hemostasis valve in the sheath, particularly when the valve is open during the introduction, removing, or exchanging of the device. Boston says the type of anesthesia is up to the doctor, but air ingress is less likely during general anesthesia with its controlled and positive pressure ventilation. They recommend avoidance maneuvers, such as to make sure that your patient is not hypovolemic, and also to make device exchanges with the access system below the level of the heart or under fluid, and withdraw devices slowly until near the valve, then make exchanges during expiration, which is easier said than done in the lab when a patient's breathing like a freight train unconscious sedation. The FDA listed the sheaths, and it includes only the TruSeal FXD curve and the TruSteer access system, and they also say that an investigation, quote, concluded that the increased likelihood of air embolism is not associated with the design or manufacture of any component of the Watchman system, end quote. So my comments. I think air embolism here is not likely related exclusively to the Watchman device. It sounds more like a physiologic phenomenon wherein patients on conscious sedation can take these huge breaths, which, if timed unfortunately during opening of the valve of the sheath, then air could be sucked in. We worry about this a lot during AF ablation, and sheath management is crucial. I always remove catheters from sheaths slowly. And I absolutely hate catheter exchanges. It's actually one of the negatives of PFA technology right now. That we have to use a separate mapping catheter in PFA means we have to exchange catheters. Now that's going to soon change. So what Boston Scientific is recommending seems to me to be basic procedural hygiene when in the left atrium. I wonder, though, whether this new warning has to do with this new system of sheaths, or is it just more doctors, many of whom are low-volume operators, doing more cases because of the device's popularity? I mean, there have been tens of thousands of cases of left atrial appendage occlusion since 2016, and now, in 2025, 9 years later, we get an alert on specific catheters and sheaths. If I were an implanter, I would be curious about this question. We've done this procedure for a long time, but now with this new system, we see a problem. Why? Are we sure about these valves? I'm asking. I don't know. That said, FDA warnings are common with all cardiac procedures. That's because we're learning things during the iterative process for all procedures. For instance, we did not know about AE fistula, atrial esophageal fistula, after AF ablation until tragedies occurred. Thermal ablation evolved to avoid heat stacking in the area of the esophagus. So I am glad companies issue such warnings. Transparency is laudable. The larger lesson here, I think, is that procedures can cause harm. Their evidentiary basis should be as strong as new drugs, and often it is not. For instance, AF ablation has only one placebo-controlled trial. Tricuspid interventions have 0. And you all know how I feel about left atrial appendage occlusion procedures. There was failure of the seminal Watchman trials to show non-inferiority to warfarin. Never forget that the PROTECT AF trial did not pass FDA muster, and the PREVAIL AF trial failed to meet non-inferiority in its first co-primary endpoint of stroke, systemic embolism, and cardiovascular death. And there's no compelling evidence for the left atrial occlusion device in patients not able to take oral anticoagulation. And it's been 9 years that we've been doing this procedure. But the main lesson is that when we intervene on patients who have symptoms, say symptomatic AFib, symptomatic tricuspid regurgitation, myocardial infarction, we are intervening on patients who have an active problem. When we intervene on the left atrial appendage, we are doing prevention. We seek a probabilistic benefit in the future. Prevention must always have a higher, not lower bar of evidence. It doesn't with left atrial appendage occlusion, and I think this is a blemish on our profession. All right, final topic today is switching oral anticoagulation in elderly frail patients. Jack has a very nice paper on the issue of switching oral anticoagulation in older patients who have frailty, and this comes up a lot. Now, of course, anticoagulation naive patients, new prescriptions, at least in my neighborhood, get a DOAC. I can hardly recall the last time I started warfarin de novo in any patient with AFib. Now, we do this mostly for convenience, but also for efficacy and safety. The issue at hand is not de novo patients. It's whether a patient on warfarin should be switched to a DOAC. Now, I reported in 2023 on the Frail AF study. This was a Dutch study that randomized about 1,300 patients who were older than age 75, frail, and treated with VKAs, i.e. warfarin, to either switch from the VKA to a DOAC or to remain on VKAs. The trial was stopped prematurely for futility as there was a significant increase in major or clinically relevant non-major bleeding, mainly gastrointestinal bleeding, in patients who switched to DOACs. The hazard ratio in Frail AF was 1.69 and confidence intervals went from 1.2 to 2.3. Frail AF was provocative because it was surprising. You would not have thought bleeding would have gone so much higher when switching. Now, the critical appraisal of Frail AF trial at the time included very wide confidence intervals and a low number of events, and the confidence intervals were made wider by the early termination of the trial for futility. The current study, the TIMI group, led by Dr. Robert Gugliano, has formed a combined AF collaboration. This is a patient-level meta-analysis of the 4 DOAC versus warfarin trials: Rely, Aristotle, Rocket, and Engage. Now, that's a lot of data, and this is a much better use of meta-analyses than the first paper I discussed on AF ablation. This sub-study of the combined AF study set out to replicate Frail AF in a larger population of these 4 trials. It's a neat analysis, and here's what they did. They took patients who were on VKA, and they called them the VKA experienced arm when entering the trial, and elderly patients and frail. For frailty, the investigators had to make a frailty scale based on a number of factors, which was different from the scale used in Frail AF, and it may be important. Also note here that VKA and warfarin are almost interchangeable. Now, this group, warfarin experienced, so on warfarin, old, and frail, were then randomized in the trials to DOAC or warfarin. And there were about 6,000 of these Frail AF-like patients in the 4 trials. They have split equally into DOAC or warfarin arms. The authors called these the test groups. Then they can just look at outcomes. They also looked at patients without these characteristics. This group were either VKA naive, or they were not elderly, or they were non-frail. And there were 52,000 of these, and the authors called these the non-test group. The main outcomes that they were looking at were stroke and systemic embolism, major bleeding, and mortality. Now, they also looked at GI bleeding and intracranial hemorrhage and fatal bleeding, but I think those subsets of bleeding are less important than the big categories: stroke, bleeding, mortality. Here are the findings. Finding number 1. In the Frail AF-like population over 2.5 years, for the DOAC group, there was a 17% reduction in stroke and systemic embolism that did not reach statistical significance. The absolute risk reduction was 0.4%. There was also no difference in mortality and no difference in major bleeding outcomes. Now, looking at specific types of bleeding, in the Frail AF-like population, randomization of DOAC versus warfarin was associated with an 83% increase in GI bleeding that was significant. That's a 1.5% absolute risk increase, but there was a 54% relative risk reduction in fatal bleeding, though here the absolute risk reduction was only 0.3%, of course, because there were fewer events. And then when looking at net clinical outcome in the Frail AF-like group, the hazard ratio was right at 1.01. Finding number 2, when compared to the non-Frail AF population, the 52,000 patients who did not have one of the 3 criteria of VKA naive, elderly, or frail, These results were exactly similar to what you'd expect and what was seen in the main trials, and that was that DOACs had a statistically significant reduction in the risk of stroke, death, and major bleeding. The net clinical outcome in these patients was statistically significant at a hazard ratio of 0.89 in favor of the DOACs. In finding number 3, the authors did a special analysis based on the type of DOAC in the Frail AF-like group. Recall that in Frail AF, the main DOAC that patients on warfarin were switched to was rivaroxaban. It was about 53%. In Combined AF, the main DOAC that they were switched to was apixaban and edoxaban. So when the combined authors simulated this in their data, they found that when using the, quote, same DOACs mix as Frail AF, that was rivaroxaban 54%, apixaban 19%, edoxaban 18%, and davi 9%, they found no statistical significant differences in stroke and systemic embolism, but now they found a statistically significant increase in major bleeding. The hazard ratio point estimate was 1.21 and an even larger 2.2x increase in GI bleeding. But on the other hand, when they did this sub-analysis on apixaban and edoxaban only in the Frail AF group, they found similar stroke and systemic embolism rates, but now a 17% significant reduction in major bleeding and only a 36% non-significant increase in GI bleeding. So the author's summary is that, like Frail AF, switching from warfarin to DOAC had no significant effect on stroke or systemic embolism. So in terms of efficacy, it was a wash. But unlike the Frail AF study, which had to be terminated early for more bleeding in the group that switched, the Combined AF, Frail AF-like group did not sustain higher rates of major bleeding when switching. GI bleeding was higher with the switch, but fatal bleeding was less. Frail AF, therefore, does not replicate in this data set. And the authors of Combined dispute the Euro guidelines, which give a new Class 2 recommendations to maintain warfarin in elderly frail patients based on the Frail AF trial. And they write, strongly I would add, quote, the findings from this study suggest that switching to a DOAC is a reasonable strategy for frail, elderly, and VKA-experienced patients, particularly for reducing the risk of stroke, systemic embolism, death, and the most severe bleeding events such as intracranial and fatal bleeding. Okay, my comments. First, I think it's worth thinking about why the results were divergent. Now, one that the authors put a lot of weight on is the different frailty scores used in the two trials. Combined authors say their patients might have been frailer or at least different enough to drive results. And I'm not sure this is true. I mean, to be in a global trial requires a degree of robustness, doesn't it? I mean, Frail AF, however, included social isolation as a characteristic of frailty. And this was inability to walk around in the house and cognitive impairment, which were not available in the Combined AF dataset. I ask you, close your eyes for a second and imagine an isolated Dutch patient versus a patient well enough to come into the office and be randomized in a global randomized controlled trial. Now, another possibility is that the DOACs mix is important. The sub-analysis in this paper with apixaban and edoxaban looked a lot better for bleeding than did the rivaroxaban heavy analysis. But I would be extremely suspect here. This is a sub-analysis of a sub-analysis that is not adjusted for multiplicity. I think invoking specific mixes of DOAC is a stretch. Now, the main reason for the difference in the two studies, I think, in my opinion, comes in Figure 4 of the supplement, where the combined authors provide the number of events along with forest plots in the two studies. In Frail AF, there were 29 stroke events versus 201 in the combined study. And in Frail AF, there were only 40 major bleeds versus 551 in the Combined AF study. If you have access to the paper, take a look at the width of the error bars in those two trials. It's remarkable. Now, this is not a criticism of Frail AF. The authors did a really nice trial of a very special patient population. They were looking for a reduction in bleeding in patients who switched, and when they found the opposite, an increase, it made ethical sense to stop the trial early. And I think the lessons here for us, for the users of the evidence, are that single trials with small numbers of events should be translated carefully. You could argue that the Euro guideline author's choice of a week 2B recommendation for remaining on warfarin is careful. I was enthusiastic when the Frail AF trial came out because it was so darn provocative. I would not have predicted it. And I think it is still a great trial, but this analysis tells us that A, we should be very cautious of small numbers of events and trials, and B, as it so often is in clinical medicine, perhaps there is no exact right answer in these patients. So how I see the clinical question given this new data is that in sum, for elderly patients on warfarin, I don't think we are mandated to do any one specific thing. Frail AF said don't switch when doing well on warfarin. Combined says that if you switch, outcomes are similar. There's not a major advantage or disadvantage. But if an elderly, frail patient wanted to switch, say for convenience, say the family wanted to simplify things, combined results would argue that outcomes would be similar. Hence, switching should neither be proscribed nor recommended strongly. It can be a shared decision with the patient and his or her family. And recall also, I'll close by saying this, it's not about initial choice, which I think remains a DOAC. This is about patients on warfarin and considering switching to DOACs. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time and give us a rating. Write us a review. I've been loving listener feedback. Every time I get it, I learn something, and so feel free to correct me if I'm wrong. Until next week, this is John Mandola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.